So before I forget. So we talked about the skeletal system. We talked about the fact that they have different shapes, and we can categorize them based on shape. We can categorize them based on their location, looking at axial and appendicular skeleton. We went into the characteristics in terms of both gross anatomy and the microscopic anatomy of the long bones and the compact bone, when we looked at things like diaphyses, epiphyses, the epiphyseal plate, your medullary cavity, etc. And then in terms of microscopic, we took a look at your things like osteon, central canal, lacuna, osteocytes, etc. And then one thing that we started, but we didn't really finish, was basically bone development. And I said that when you look at bone development, there are two main types. One is the one that's called intramembranous ossification, and the other one is called endochondral ossification. And we said, if we look at majority of the bones, with the exception of some of the skull bones and your clavicle, which is your collarbone, all of your bones in the body actually go through the process called endochondral ossification. And then from there, basically the two other type of bones, which is again a skull, some of the skull bones and the clavicle, go through a process called intramembranous ossification. So we're going to briefly talk about both of these. Now, I do want you to understand that these processes that I'm describing here are definitely more complicated. They involve a lot of molecular processes that are not described here, but we're just kind of going over the brief overview of these, the steps that are involved in either form of the osteogenesis. So the first thing that we're going to talk about is the intramembranous ossification. So what you see right here as this blue background, these are what we call stem cells, which are basically the original cells that develop into all the different type of cells we have in our body. One of the type of the stem cells that we have in our body comes from a layer called mesoderm. You don't need to know that word. However, the name of these cells associated with this layer is called mesenchymal cells. So mesenchymal cells, which are these kind of like a spindly shaped blue color cells you see in the background. So during the intramembranous ossification, one of the first things that happens is some of these mesenchymal cells that are located in the area of the bony tissue, when they want to be a bony tissue, they start to undergo what we call a differentiation process. Basically, they say, okay, right now I'm a mesenchymal cell. I can be whatever I want, but I want to differentiate into bony tissue. So they make that the distinction that they want to become bone tissue. So mesenchymal cells actually undergo differentiation process and become the immature bone cells we learned about last time called osteoblast. So mesenchymal cells, which are these blue cells, again, you see in the background, some of them undergo changes and become osteoblasts, which is these kind of cube-shaped cells that you see at the center. Now, when these osteoblasts are forming this collection of cells are now called the ossification center, which is basically means that's where the bone is starting to develop and grow. Now, what they do exactly is these osteoblasts are going to take calcium from your blood. They're going to take phosphate from the blood, and they start depositing it around themselves. So what you're starting to form is what we call a bone matrix or osteoid. So the bone matrix starts to form around these osteoblasts. Now, one thing you notice about this picture is the following. You have some of these cells that are kind of trapped inside. So like these two that you see right here. And then you have cells that are surrounding the bony tissue that's being formed. So the ones that are still free, they're not trapped inside a space, they remain as osteoblasts. However, the ones that get trapped inside the osteoid, inside that bony tissue, are called osteocytes. And you guys remember osteocytes are basically identified as mature cells, right? These are cells that are basically now responsible for maintaining your bony tissue. So the next thing that happens, the next process, is that you start to form woven bone. So from that structure that you originally formed, which is basically the osteoids, and you had trapped osteocyte inside of them, you form something called woven bone. All this is for woven bone, and all that you need to know is basically you start to create these openings or holes inside called trabeculae, and then you start to pass your tiny little blood vessels, as you can see, into that bone tissue. So you started with a kind of a compact bone, and now you create little holes inside of it and pass blood vessels through it, and that becomes the woven bone. The other thing that is happening is some of the mesenchymal cells that we have on either side. So these little, again, the spindly blue cells that you see around are going to condense around the bony tissue. And what they're going to form is what we call periosteum. Anybody remember what periosteum was? Does that sound familiar? We talked about it last time. Anybody recall what that is? No? Nothing? Okay, so hopefully you guys are gonna go study sometime soon. So periosteum was basically the connective tissue that is wrapped around your whole bone. So basically what you're doing is you're creating the wrapping around your bony tissue right now. The last thing I want you guys to know, which is the fourth step that's listed here, is two things. One is you start to form your compact bone on either side. So here's your compact bone basically, and here's your woven bone or your trabeculae at the center. And then the other thing is that you start to see red bone marrow. Now you guys remember bone marrow, right? Red bone marrow, what is the function of that? Anybody recall that? It is responsible for formation of what? Red blood cells, white blood cells, and platelets, which is simply put is all of your blood cells, correct? So if you're looking at this process, basically, if you're looking at it in an overview, kind of simplifying it, you start with mesenchymal cells. Some of them become osteoblast. Osteoblast secretes its matrix, which is calcium and phosphate, trap some of the cells, and those trapped cells become osteocyte. You create holes that is called the woven bone and introduce blood vessels into it. You put a membrane around it, which is your periosteum. And then the last thing you do is you create your compact bone on either side and add your red bone marrow, which is necessary for blood cells. So up to this point, understand guys, up to this point, your body is unable to produce your own blood cells. So that fetus is basically relying on the mom's blood to get the oxygen into the system. After this point, basically, the baby starts to produce its own blood cells, which is kind of cool to know. Any question about this one? If so, type it in, please. Now, the second type of bone formation we have, or ossification we have, is called endochondral ossification. And I broke down the word for you guys last time. It's basically endo was inside, chondro means cartilage, and ossification means bone formation. So we're basically saying that the bone formation happens from within the cartilage. So the main difference when you look at this one versus the previous method of bone formation I talked about is that we actually start with hyaline cartilage as our starting material. So you kind of have this blueprint of what the bone would look like. However, as the process, as the basically fetus starts to develop, which is around the second month, then the hyaline cartilage starts to give away to bony tissue. So there's a transformation from cartilage to bone that actually starts from the second month of fetal development, and it basically continues all the way to adulthood, basically all the way to the stage where the person is growing. When the growth is done, then this process of endochondral ossification also ends. So it's a relatively long process. So what do you need to know? Again, simplified version of this process. This is a lot more complicated than what you see here. So what you start and what you see here in these pictures to kind of help you understand, anything you see in blue is cartilage tissue, which is hyaline cartilage. Anything you see in that kind of bony color basically represents your bone. So that kind of yellowish color. So the first thing you do is you form what we call a bone color. So you see these bone color forming right at the midsection of the cartilage. And then you form what we call primary ossification center, which is sometimes, it's not identical, but it's something similar to what you would have seen on the previous method. Now notice as time passes by, so we're kind of hitting between months 2 and 3 of the fetal development, this cartilage is starting to grow. But what you must notice here is that the actual cartilage at the center is deteriorating. So you're getting rid of the cartilage basically. And what you're doing is you're readying that space for bony tissue. So you're getting rid of the cartilage at the center. It's kind of like, think about it, a termite is eating the cartilage away, and you're opening up a space within that cartilage for your bony tissue to develop. So the second thing that is happening is you're introducing a blood vessel. So you can see a clear blood vessel coming into it. And this blood vessel is basically coming and filling up this cavity. Why is this important, guys? So this is something that's not here, but you do need to know. What makes it deteriorate? It's something I don't want to go to it. You don't need to know it, but I'm going to just briefly go over it. What happens is these cartilage cells start to produce a lot of material around themselves. So they kind of trap themselves into that space, and they can't receive any nutrients and oxygen. So the cells, these cartilage cells, actually start to destroy themselves. Like they literally, by overproducing material around themselves, they trap themselves and kill themselves. So if there is no cartilage cell to maintain the tissue, basically the tissue starts to deteriorate. And that's what the process is. You don't need to know that though. You just need to know the cartilage starts to deteriorate. Hopefully that answers your question. Okay, so you bring in your blood vessel in the third place. And what you bring in with these blood vessels, so focus on this. You're going to bring in your osteoblast and osteoclast. So osteoblasts are the ones that are going to help you form new bone tissue, and osteoclasts are the ones that are going to help you destroy the bony tissue. So you guys are going to, again, remember there's a balance between these cells. Now, as these cells get introduced, as these osteoblasts and osteoclasts are introduced, you start to create your medullary cavity, which should sound familiar to you since we already talked about it. And on either side of this, you start to form your compact bone. So here is your compact bone on either side and medullary cavity right at the center. Something else that is happening is these things that you see in the epiphyses of the bone, the ends of the bone. You form what we call a secondary ossification center. So remember primary ossification center here? Now you form 2 at the ends, and these are called the secondary ossification centers. So basically your bone is undergoing the same changes at the end as it went in the middle. Now notice this, guys, by birth, you still have a significant amount of cartilage tissue as part of your bone. So, you know how I was telling my students, you know, when like you deal with toddlers and infants, and you kind of look at them and they like feel really rubbery and they're doing movement and you're like, how are they doing this? Or like you grab your hand, I don't know if you ever try to hold a toddler, they kind of like a fish that try to escape, or they twist in a certain way that you're like, how are you doing this? Like, how are you not breaking a bone by doing these movements? The main reason is because these bones are actually not hard. They're relatively soft bony tissue because they have a lot of cartilage, and cartilage is softer than bone. So they have a lot more flexibility compared to an adult. Now, by the time the person basically undergoes through their childhood and development, what is happening exactly is the bone that you see right here, guys. So here's a really important thing, guys. If I ask you, by the end, when you reach adulthood, where can you find cartilage tissue in your bone? Okay, where can you find cartilage tissue in your bone? You will have them in two locations. And this is something we described also when we talked about the gross anatomy of the long bone. One place is the epiphyseal plate, which is this space right here. It was a space between the epiphysis and the diaphysis of the bone, so the ends of the bone and the shaft of the bone. And this is extremely important for the growth of the bone. So this is basically, this area is what allows a child to grow. After the child has undergone its growth, then it changes to what we call an epiphyseal line. So I'm gonna make a quick note for you guys in your chat box. So please make sure you understand this. So epiphyseal plate is during childhood, but epiphyseal line, it's the same structure. Epiphyseal line is what we refer to it in during adulthood. Both are made up of hyaline cartilage. The only difference is that the epiphyseal plate is used to grow the bone, versus epiphyseal line is just there. They're not really helping the bone grow. So basically the person has reached its maximum height or growth rate. So make sure you guys distinguish between the two vocabulary. Now, again, another place where I can find hyaline cartilage on my bone is the articular cartilage, the surfaces of the epiphyses. Anybody remember, why do I need this cartilage right here on these ends, on the ends of my epiphyses? Anybody recall that? Lubrication, correct. So lubrication in terms of if I have one bone and another bone, I don't want them to be rubbing against each other. I want to limit the friction, correct. So limiting friction in your bone are done by covering it with articular cartilage, which is a still hyaline cartilage. Is this making sense, guys? Is there any question about this process? If so, please type it in a chat box. I don't know if I'm going too fast for you guys, if it's everything making sense. Hopefully that is the case. But if it's not, please let me know so I can slow down. So the epiphyseal plate is the same thing again as the epiphyseal line, which is what you see right here. These blue lines right here and one right here. All it is basically the area where you have, what do you call it? Hyaline cartilage, and it's used during bone growth, which is what I'm going to talk about right now. If the bone growth is done, then the epiphyseal plate name is going to change to epiphyseal line. So epiphyseal plate is changing to epiphyseal line. Does that make sense? Okay. So next thing we have is basically how are we actually growing? So I keep talking about this epiphyseal plate being important for the growth of the individual, but what is it actually doing that allows this bone to grow? So let's take a look at this. So it's described here for you guys, but I'm going to show you on a picture because I think it makes it a little bit easier to follow. So here is what you see in your epiphyseal plate when a child is growing. So epiphyseal plate, look at the words, epiphyseal plate of a growing long bone. So what you have is, again, kind of zoom in area is right here. So on the top here, if you imagine, up here is your epiphysis, and down here on the bottom of your screen would be your diaphysis. So epiphysis up here, diaphysis down here. And what's we kind of highlighting in this image, zoomed in, would be your epiphyseal plate, which is made up of hyaline cartilage. Now, the side that is closest to the epiphysis, which is up here, so this is cartilage tissue up here, you have what we call a resting zone. Basically, what this resting zone is nothing is happening in it, guys. It's just sitting there, it's happy. The cartilage cells are just kind of chilling out. They're maintaining the tissue, not hardworking. Right underneath that, this type of cartilage tissue you see, which is number 1, is called proliferation zone. The word proliferate means that they are dividing. So they're undergoing the process of mitosis, what we discussed in one of our labs, which basically means these cells are undergoing continuous division to make more and more of themselves. Now, the next area we have, which is this area, number 2, this is called hypertrophic zone. These are basically where the tissue is starting to deteriorate. They're starting to basically destroy themselves. It's the beginning of the end for the cartilage tissue. You have this area, number 3, which is the calcification zone, which is, again, the start of you transferring the cartilage to bone tissue. It's the region where you're starting to transfer or convert your cartilage tissue by destroying it and converting it to the bone tissue. And lastly, what you have is what we call the ossification zone, which is basically the area where you are forming your bone tissue. Your actual bone growth is taking place on this side. So let's kind of refocus. If I ask you guys, do I increase the length of the bone? Pay attention. Do I increase the length of the bone from the diaphysis end or the epiphysis end? What would you say? Do I increase the size of my bone from the diaphysis end or the epiphysis end? What would you say? Okay, which end? You guys are saying just the end. So am I increasing it from the epiphysis end, which is the chubby part on the top on this image, or am I doing it from the bottom part, which is the diaphysis? From the diaphysis, correct. Because this is where the calcification happens, right? So this is my diaphysis down here, and you're adding bony tissue from the bottom. Where does my cartilage growing? Which end is my cartilage growing then? Remember proliferation, which means mitosis, which means cell division. It happens up here, right? And that's your epiphysis end, correct? So pay attention. I'm going to repeat the question again for you so you guys have an understanding of this. If I say, which side of the epiphyseal plate do you add cartilage from? You're adding it from the epiphysis end. Which end does your bone grow from through the process of calcification? Then it's through the diaphysis end. Let me put this in a different perspective for you and kind of add a layer to it as well. Imagine you have one of those containers that you use for lemonade, that like you have the big opening on the top and the little opening on the bottom for people to get their drinks from. I don't know what they call them. I call them a big bucket. I'm just kidding. So Imagine the top portion is the epiphysis end, and the little valve on the bottom is your diaphysis end. So I'm adding cartilage from the top, right? And I'm converting the old cartilage from the bottom to the bony tissue. So if a person is growing under normal conditions, so we're talking about children and adolescents, the amount of cartilage that I would be adding on the top, okay? So the proliferation zone, the amount of cartilage this area is adding is equal to the amount of the bony tissue that's becoming or forming. So the amount of that I'm adding from the top is equal to the amount that is leaving from the bottom as bone tissue. So if I ask you this question, in a child or in an adolescent, which are undergoing growth spurts, does the size of the epiphyseal plate change? What would you say? Does the thickness of the epiphyseal plate change? Yes or no? So everybody's saying yes. Now I'm going to repeat my question because the actual answer is no. So listen to what I'm saying. So epiphyseal plate is what you're highlighting here, right? This area. So if I'm saying if I'm adding cartilage on the top, right? And that same amount of cartilage that I'm adding on the top, from the bottom, we're replacing that with a bony tissue. Would I change the thickness of my epiphyseal plate? And the answer is no. Is this making sense why it's no? Sure, let's put that on that excuse. So to imagine like you have your lemonade, guys, and as people are drinking from the bottom, right? Same amount is being added on the top. Then the level of the lemonade will not change, right? You will keep the same amount. That's basically what I'm saying. You're adding cartilage on the top, as the same amount you're converting it to bone tissue. So the same ratio, basically, correct, then the amount of your the thickness of your epiphyseal plate will not change. It stays the same. Now, here's the thing. What happens when that person is transitioning from basically from adolescent to adulthood? Yeah, pay attention to this, guys. During that process, the proliferation zone, which is responsible for adding cartilage, it slows down. Okay? The rate that I was forming bone, it stays the same. So I'm adding less cartilage on the top, but the amount of bone that I'm forming is stay constant. So in that case, what happens to your epiphyseal plate? Does it get shorter, stays the same, or get longer? Okay, it gets shorter, correct. So it gets shorter because, again, think about the whole scenario of the lemonade. I'm adding less lemonade on the top, but I'm taking the same amount as before out. So I'm taking more out and putting less in. So my epiphyseal plate starts to get shorter. So you're basically gonna come up and say, I'm gonna change this to bone, la, 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 la. So proliferative zone eventually stops, right? So you're gonna reach what? What we call the resting zone. The resting zone, you can't touch it. It says, I'm already done. I'm not part of this process. So I'm not even getting involved in this. So I'm gonna stay where I am, okay? So you can't touch that resting zone. So because you cannot touch that, now your epiphyseal plate has become what? What is it transitioning into? Plate becomes what in an adult? It becomes a line, correct. You still have cartilage tissue, but that cartilage tissue is not going to be used for growth. So we cannot use the word plate. So we're gonna use the word line for it. Is this making sense, guys? It's a pretty cool process. So one quick kind of overview. When you're growing, when the child is growing, when during the adolescent, you have what we call an epiphyseal plate. You add cartilage on the top. At the same rate, you're changing the older cartilage to bone. The epiphyseal plate remains the same thickness. As you reach adulthood, then the amount of cartilage you're adding on the epiphysis end slows down, but you still continue with the same rate of bone formation. So your epiphyseal plate gets smaller and smaller and smaller until it actually forms a single line, which we refer to it as the epiphyseal line. So when you form that epiphyseal line, that person will not be able to grow any farther than that. So they're done. They basically reach the end. It's the easiest way to think about it. Not end of growth, I meant, not end of their life. Question about this? Any clarification on that? No? We're good? Okay. So this picture, I like it because it can see kind of the distances between the bones. So right here, in this case, see, this is basically your metacarpal, the bones on the palm of your hand. So you can see a gap. This is still one bone, guys. This from here all the way to here is one bone, but you can clearly see that it looks like the bone is like separated. There's like two pieces of it. But now look, it's a line. It's a clear line. So when it's separated in an X-ray, cartilage looks black. So that's why you see that clear kind of separation in your bone. Versus when it becomes a line in an adult, you basically see a very minor line in it and nothing very pronounced in it. So, you know, when they say if people actually look at X-rays and if it's like basically just a skeleton, the best way for them to determine how old is a person is looking for the epiphyseal line. So they can get a really good estimate of the age of that person when they look at their bone tissue and the development of the skeletal system. Because by the time, again, we reach adulthood, all of your epiphyseal plates will be closed. This is another very pronounced one that you can see in your radius, really pronounced separation. It's like, the people, it's like, what? I thought that was a fracture, or that's, you know, the bone broke. No, that's just literally a cartilage line right here, which helps the person grow. So there is a separation between that. In terms of your questions, as far as when that ends, it depends when that growth ends. For some people, it's a little bit earlier on. For some people, they're a little bit later. It says typically about age of 25, you have reached your maximum. So your epiphyseal plate would have changed to epiphyseal line by that age. So it says, on the slide, it says, at the time of your adolescence. So basically, sorry. So as an adolescent, basically, you start to see a significant change. And the biggest change you can see in children is the production of hormones, right? So when they basically, at adolescence, they start to reach puberty. And typically for most people, and again, there are always exceptions to that rule, for that, you always going to have, as the hormonal level increases, the growth starts to decrease. So it's marking literally the beginning of the end for the growth. So as I said, the epiphyseal plate is becoming thinner, cartilages start to growing, and eventually gets replaced with the bone tissue, which is what I was describing to you earlier. At that point, you have basically the long bones lengthening or growth is starting to end, and you have the diaphysis and the epiphysis coming together with the merge line for your epiphyseal line. Now, again, remember, by this time, when you get to this stage, and this is something that I described to you guys previously as well. If you're looking at a child, okay, or an adolescent, the activity of the osteoblasts, which are the ones that are forming the bone, are higher than you breaking down your bone. So osteoblast activity are higher than osteoclast activity. When you are a healthy adult, okay, so we're talking about people between the age of 25 to about 50. Again, that number is, there is definitely a range for it. Your activity for osteoblasts and osteoclasts is usually identical. So you have basically the amount of bone that you're destroying, you're producing the same amount. So your bones are staying relatively healthy. When you're past that age of 50, which is something we talked about last time, we talked about menopause for women, right? Pregnancy for women. When things like this happen, what you will see is typically in relation to the two, osteoblast activity is less than osteoclast activity, and that makes you susceptible to things like osteoporosis, right? Bone density starts to decrease as you start to age. So that's the main or significant difference that you see when you compare an adult, a healthy adult, versus someone that starts to go over the age of 50. Is this making sense? Any questions for you guys? Anything that you would like me to explain? Okay. So in terms of the growth of the bone, what I described to you was associated with the long bone. There is a brief description of what happens to short, irregular, and small long bones. I don't really necessarily want to spend time on this since most of the bones that you have in your body are identified as long bones, but you guys are welcome to kind of glance through this slide and just briefly go over that, but that's something a major thing. Now, in terms of the growth of your epiphyseal plate, a couple of things that I want to mention, and I'm not going to go into details about this. This is literally all I want you guys to know. It's associated with your endocrine system and how secretion of the specific hormones have an effect on the epiphyseal plate. You will, of course, learn a lot more about this when you go to your physiology class. So some of the hormones that does affect on your bone growth is, the name, as the name implies, is growth hormone. So growth hormone is produced by what we call the pituitary gland. It's a tiny gland that sits inside your brain. If you guys recall from your skeletal system, in a space called sella turcica. The growth hormone is basically stimulates the epiphyseal plate. So cool fact, you know how like you take your kid to pediatrician and they measure and they make sure that that child falls within the normal range for their growth. So a lot of times if they don't see that growth rate, one of the first things that they measure is the level of growth hormone in their bloodstream. And for some kids, because of issues with the pituitary gland, the level of the growth hormone is less. So what they recommend, not for everybody, but what they can recommend is a daily injection of growth hormone over a period of time. And those growth hormone can help basically lengthen that individual. The problem is that, you know how some people are late bloomers, so they may not grow at the beginning, like when the age of 8 or 9, but then they start to do hormonal therapy and then they start to hit growth spurts at age of 10 or 11. So basically they get a double dosage of growth hormone, and that causes kind of irregularity. So the doctors, a lot of the doctors or pediatricians are not for this, the injection of the growth hormone, but it is a possibility in terms of treatment. Thyroid hormone is another one. I think everybody has heard of thyroid hormone at some time in their life. The location of the thyroid gland that produces the thyroid hormone. Anybody knows where that is? Anybody knows where the thyroid gland is? In your neck, correct. So it's right about here. It's a butterfly gland that sits right here. And it, in terms of growth, it makes sure that basically your proportion of their skeletal systems are the same. So basically, as the bone is lengthening, for instance, it's also growing in width. So your bone doesn't become super skinny or super thick. So you want to have that proportion. It's really, really important. And then sex hormones, things like testosterone and estrogen are important in terms of bone growth at the beginning of the process, but is one of those hormones that as the level starts to go up, so basically as they start to reach adolescence and the level starts to kind of go up the scale, then that actually stops the bone growth. So it marks the beginning of the end, basically. So this is all these hormones, the sex hormones is one of the cool ones. Low level of it, good. It helps the bone growth. But as the level starts to increase, as the person starts to reach closer and closer to the puberty and reach the peak of puberty, then it actually causes a decline in the bone growth because it says, okay, you guys are becoming adults, basically. This is kind of cool because I like to just kind of show you the activity of the bone. So remember, I keep telling you osteoblasts and osteoclasts are working together. So here you have these kind of larger cells, which are your osteoclasts, and these are smaller ones, which are your osteoblasts. And I mentioned this, that they said, as your osteoclasts basically eat away your bone, the old bones, your osteoblasts come right behind them and reform that same bone. So you're not really getting rid of the bone if you are a healthy adult. Osteoclast destroys the bone, and then right behind it, osteoblast comes in and replaces the bone with a new tissue. I mentioned this to you guys last time that all of the bones in your body gets replaced every so often. Do you guys remember how long did it take in average? 7 years, correct. So in about 7 years, you're basically doing this continuously. You're getting rid of the old bones and replacing it. So, you know, that's why they tell you, again, do a lot of resistance training, because the more resistance training you do, the better your chance are of preventing bone damage in the long run, because you kind of controlling the activity of the osteoblast and osteoclast and helping you form a stronger bones because of that extra resistance on the bone tissue. Okay. Here's basically a picture of the osteoclast cell. And again, we said osteoclasts are larger than your osteoblast. They are not bone tissue. They actually can identify as blood cells. And the really, really cool characteristic that I mentioned last time is inside of these osteoclasts, you have a very acidic environment. And that acidic environment is created by hydrochloric acid. So hopefully all of you guys have heard of that. Hydrochloric acid, or HCl, is basically what you also have in your stomach. And with the help of some enzymes in the lysosome, you literally break down your bone. So here's a question for you guys. This is something, again, I mentioned last time, but use your logic. If in what condition would your osteoclast activity increase? I'm not talking about the age, guys. So let's say a person is an adult. In what scenario their osteoclast activity will increase? Anybody has any idea? Okay, poor diet is very generic. What does that exactly mean? Gene is not as effective because, so go back to the poor diet. Poor diet in what? Not a lot of calcium, correct. Remember we said calcium needs to be maintained. So when you were a kid, your parents keep telling you eat calcium, eat milk, you know, eat vegetables, because a lot of them are high in calcium, including like things like a spinach. A fish is high in calcium. So what you do is you eat these things that are high in calcium. But let's say you have an unhealthy diet, okay? And by unhealthy diet, I mean like you eat fast food all the time, which has other problems, no green leafy vegetables, no dairy products, or soy or almond milk. So all of these are basically taking away calcium from your diet. Your body still needs calcium for day-to-day activities. So it says, okay, you're not giving me calcium, but I still need calcium. So where can I go to get that calcium? And your body says, well, I have a lot of calcium in my bone and my teeth. So what do? I go over to the osteo class and I tell them, start breaking my bone and release that calcium into my bloodstream. And by doing that, you're basically tapping into the reservoirs of the calcium in your body. Again, a small amount is not bad, but if it is a continuous process, it can lead to osteoporosis, which basically means your bone density becomes less and less, makes you more susceptible to fractures, etc. So keep that in mind when that things happen. In terms of repairing your bone, I'm not sure what you mean, are calcium vitamins good? If you're talking about supplementing, I'm not really for supplementing. So supplements, especially if you're a healthy individual and have a normal diet, you should not be supplementing. That's what I tell everybody. If you are pregnant or post-pregnancy, then yes, taking supplements as part of your prenatal, even after you gave birth, is a good idea, especially again if you have multiple kids. But especially if you're a male, you do regular exercises, you have a healthy diet, you should not be taking supplement at between age of 25 to 50. Calcium and a lot of things, a lot of people just don't include that. Calcium causes a significant damage to kidneys because it takes a lot of effort for the kidneys to pass this. And it causes kidney stones, it can cause renal failure, etc. So it's something that I wouldn't recommend unless your doctor tells you, okay, you're low in calcium, start taking those supplements. But by yourself, I wouldn't take any supplements unless it's recommended by your doctor. And I know the culture of the US is that, oh, I haven't ate very well, let me pop a multivitamin into my mouth and, take a calcium pill supplement and I'll be fine. No, it's not really a good idea. And the other thing that I would say, and this is true for everything in terms of multivitamins and supplements like calcium, magnesium, zinc, etc. The percentage you get in your pill is significantly higher than what your body needs. And some of this can be retained by your body and actually cause long-term damage to your body. So I'm not for it. I don't take it unless my doctor recommends it. Typically, if you're here, the one that they usually recommend for maybe the age of 25 to 50 is vitamin D, but that's about it. Unless your doctor recommends it, please avoid taking multivitamins. Do not give your kids multivitamins, give them a healthy diet. I don't know, you go out and you see literally lines and lines and lines and lines of multivitamins and for kids, chewy, or it's apple, etc. No, avoid it. I wouldn't. That's my opinion though. So yeah, and please just don't give your kids vitamins or mineral support. That's just not needed. If you have a healthy kid and they're eating a normal balanced diet, give them fruits, guys. Don't give them calcium pills. Okay, so now let's take a look at the bone fracture. So we keep talking about basically damage to your bony tissue. So there are actually different type of fractures that we have. We have what we call a compound fracture versus simple fracture. So simple fracture simply means that the bone is broken, but it's not penetrating the skin. So you can't see the broken bone, you just have the pain. Compound fracture is typically what you see in severe traumas where the bone actually breaks through the muscles and the skin and it's visible. So the fracture is visible. Now, to treat this, usually what you do is you either get a closed reduction or open reduction. Closed reduction is a very typical process where you basically set a bone without having surgery. So when you say closed reduction, it implies there is no surgery. Open reduction, however, you definitely need surgery because you need to set the bone. A lot of times they need to add, metal bars and pins and fix the damaged tissue around the fracture to make sure there is no internal bleeding, and that's referred to as an open fracture. Yeah. If it's a picky eater, then yes. But I would talk to the doctors before I would decide to give them multivitamins. There was a question on the chat box. So regarding your kids and multivitamins and any supplement, I will talk to a pediatrician before you give them anything. That's my strongest recommendation. That's what I always tell people, and that's what I do for my kid. So, okay. So we have 6 main type of fractures. And again, there are other type of fractures, but we're going to talk about 6 main type. And again, these ones, you need to know the definition and who's more susceptible to these fractures. So the first one we have is a comminuted fracture. So typically when you think about a bone breaking, you kind of think about here's a bone, you break it to 2 pieces. Now, if the bone has low density, like people who have osteoporosis, typically elderly, what happens is when the bone breaks, it's not breaks to 2 pieces, it breaks to 3 or more pieces. So that's called the comminuted fracture. And again, it typically happens in elderly because they are more susceptible to this type of fracture because of brittle bones. The other fracture you see farther on the right-hand side is the compression fractures. Compression fractures is usually associated with some sort of severe trauma like car accidents or falls where the bone is literally compressed or crushed. This type of injury is very common in a spinal cord, or more specifically the vertebra of the vertebral column. Just to kind of add, my grandma was sitting on those Okta buses that transfer them from here to there. She has severe osteoporosis. So the car goes into a ditch, okay? And for you, it's like nothing, right? But for her, because of her osteoporosis, she actually ended up getting a compression fracture on her lumbar vertebra, which is, to me, unless I've seen it, I would have not believed it. But she ended up getting a compression fracture. So you can actually see the size of the vertebra, and you can see that when it's basically bone is crushed, it literally bone crumples on itself. Extremely painful, takes months for it to heal, and really you can't do anything for it. You just have to wait for it, limit your movement, and it's not like you can put a cast around it. So hopefully nobody suffers through that. A spiral fracture. A spiral fracture is when your bone is twisted. This is extremely common in athletes because if we kind of think about, let's say athlete is running a straight and somebody hits them from the side, it causes the bone to kind of create this twisting motion, and that creates what we call the spiral fracture. So again, common in sport injuries. Epiphyseal fracture is basically when there is cartilage damage to your tissue and you're separating the epiphysis from the diaphysis. So the epiphysis separates from the diaphysis. And you can see here is the epiphysis on the x-ray, and here's the diaphysis, and you basically separate those on the cartilage line. Depressed fracture is basically what you see in what we call blunt force trauma. So blunt force trauma basically causes the bone to be crushed inward into a cavity. So depressed fracture is most common in the skull fractures. Again, the skull caves in. A lot of times, if you do have a depressed fracture, that may end up leading to internal bleeding, and as a result, lead to death. the green stick fracture, which as the name implies, basically means it's kind of like when you try to break a green stick, it doesn't break completely. So right here you have little fracture on the side, but the bone is not completely broken. It bends on the other side. So this is really common in children, guys. As I mentioned earlier, because the bone is not fully formed at that point, then you basically won't break it completely because the bone is a little bit softer than an adult bone. So you might see little tiny lines of fractures, but the bone as a whole does not break. So again, that's common in children. Last, when we're thinking about fractures, so you break the bone, how does your bone fix itself? And we're gonna keep it really, really simple, guys. So all you need to know is for bone fracture is these literally 4 phrases that are written on the bottom. So for when the bone breaks, what you start to form is what we call a hematoma. And hematoma is basically because basically means a blood clots. So you have internal bleeding. The blood vessels inside the bone are ruptured, so the blood starts to pool inside the tissue. Now, as the bone starts to heal itself, the first thing that's gonna do is form something called fibrocartilaginous callus. If you guys recall, fibrocartilage is one of the hardest cartilages that we have among the 3, or it is the hardest actually. So what you see in this blue color, that's your callus of the fibrocartilage is starting to form, basically kind of setting up the lines for what the bony tissue eventually becomes. Now, fibrocartilaginous tissue, as it grows, it becomes a bony callus, which you can see again that transition is taking place. And then at the end, we have basically what we call bone remodeling. So basically make sure everything looks nice and neat and your bone is fully recovered. Again, very simple, don't make it more complicated. Hematoma, fibrocartilaginous callus, bony callus, remodeling. That's all you need to know for this stage of healing a fracture. And that usually in a healthy adult takes about 8 weeks. In children, are actually much faster. Is this making sense? Any question about the fractures? Any clarification on anything? Okay. So let's take a look at osteoporosis. We mentioned it already. Basically here on this picture on the left-hand side, you can see a healthy, a spongy bone. You can see there is no damage to these trabecules. Here is a termite-eaten, sorry, osteoporosis bone, which is literally look like a piece of wood that a termite or a group of termites have gone through. So there's a lot more holes inside of it. So imagine you're putting pressure on this bone versus this bone. This is a lot easier to break, right? It's much more brittle. Now it says the process, it says, look at the words here. It says bone reabsorption outpaces bone deposition. So what this means is bone reabsorption means formation of the bone. So we're basically talking about the not formation of the bone, breaking down the bone. You breaking up the bone, which is done by your osteoclast, outpaces, which means it's doing it faster than bone deposition, as in you're adding bony tissue, which is your osteoblast. So as I mentioned, osteoporosis happens because in relation to one another, osteoclasts are going to be more active than your osteoblast. Again, it's most common in women with menopause. I don't know why I have this empty slide. Treatment of osteoporosis, the most traditional way is taking calcium supplement. which is, I should say, calcium and vitamin D supplement. They have to go together. Weight-bearing exercises, this is really important, guys. So when you do weightlifting, so resistance training, I'm not talking about cardio. Cardio is great, but not necessary for bone formation. So weight-bearing exercises help your muscles become bigger. And because bigger muscles are connected to your bone, your body says, okay, bigger muscle means I need to make my bone stronger. So when I do weight exercise, I build both my muscles and bones and prevent the osteoporosis from developing. Another treatment that they suggest is hormonal therapy, which is really common for women, not for men. So especially after, again, when they reach the age of 50 and reach menopause, the level of their sex hormones significantly decreases, and that has a significant effect on increasing osteoporosis chance. It is controversial for many people, especially if you are if you have family history for ovarian cancer and breast cancer. Or uterine cancer. So basically reproductive system organs. It also increases the chance of heart attack and a stroke by forming blood clots. So a lot of women decide not to do hormonal therapy because of the risk they have to their health. So basically, I tell students that the pros and cons, the cons are more than what we consider pros. Glucosamine, I don't know. I mean, again, depends on who you ask. They do say it does support it, but if your joint is completely gone, then not really. My grandma used to take it, but again, if the cartilage is gone, then it's really not going to do anything for you. It may help you maintain it, but it doesn't help it if the damage has already happened. You do need to have that tissue replaced. Preventing osteoporosis. So how do I stop osteoporosis from happening? Plenty of calcium in your diet at your early adulthood. The more calcium you have, the more of that calcium is going to be deposited, so the less chance of your bone becoming brittle. Consumption of carbonated beverages, alcohol, actually leach away the calcium from your bloodstream and causes that to be removed from your system. So limit drinking sodas. Coffee also has it, even though I didn't list it here, and alcohol to slow down the bone reduction or bone density reduction. And of course, as I mentioned, the increase in weight-bearing exercises, resistance training, not cardio, will help significantly by building up your muscles and also through that building up your bones. And that's recommended at as earliest age as possible. So don't kind of dismiss that. Okay, osteomalacia is typically occur in adults. It is when the bones are inadequately mineralized, so they don't have enough calcium or phosphate. If that happens in children, it's called rickets. Rickets is basically happens in children, which is, again, analogous or similar to osteomalacia in adults. Have you guys heard of bow-leggedness before in children? Does it sound familiar? Anybody heard of it? Okay. So bow-leggedness is basically when you hold the kid straight, the legs, instead of being straight, they have that kind of curvature to them. That's the sign of rickets, because there is not enough calcium in the diet, calcium and phosphate actually in the diet. Then the bones are soft, so when you put weight on them, the bone starts to bend. You may actually see that in really elderly as well, when they are dealing with severe calcium loss. So that's also visiting them. Paget's disease is another one. I don't know if it's as well known as the osteomalacia, But Paget disease is when you have your body depositing extra or excessive amount of calcium into your bone. So you have a higher level of calcium deposition than your body needs. It can cause this I guess disformation. I can't think of the word now. It causes misshaping of the bone. There you go. So that's another one. And osteosarcoma is a form of bone cancer. Yeah. Deformation, thank you. So osteosarcoma is a form of bone cancer. If you do have that, that can also develop into things like blood cancer, because if it targets your bone marrow. Okay, adults, we already talked about this. The only thing that, again, I need you guys from this slide is we already talked about it in detail in the slides as we were discussing it. We talked about mesenchymal cells that produces basically the cartilage and the cell for the intramembranosus ossification. We talked about the fact that most of the skeletal system, as you can see here in this picture, are actually cartilage. They don't start as bone, and eventually they develop into a bony tissue. So nothing new in this slide. Here is the development of the bone. Again, skeletal growth continues up to the age of 21. Depending on the textbook, some people say up to age of 25. In children and adolescents, the bone formation exceeds the rate of bone reabsorption, which we already talked about. Osteoblasts do more work than osteoclasts because you want to build your bone. In young adults, the bone formation and bone reabsorption are in balance. So again, you have that beautiful balance between your bone osteoblast and osteoclast. As the person ages, then the reabsorption predominates. So your level is relation to osteoblast is higher. So osteoclast in relation to osteoblast is higher. And then that leads to decrease in bone mass, which is kind of expected. The only thing that I want to just kind of quickly talk to you guys about before we finish up this PowerPoint is about a medical condition which we already mentioned and described, but just kind of reviewing that is osteoarthritis. So osteoarthritis, I mentioned this last time, we went over it. It's also known as the wear and tear arthritis. Basically, the more you use a joint, the higher risk of that joint being or developing osteoarthritis at later years. It is when the cartilage tissue that lines the bone worns out. And as a result, then the bone is going to be rubbed against another bone. Because of the severe friction, the bone starts to lose its shape. So if you kind of rub something really rough against each other, they start to lose their beautiful shape, and it causes a significant amount of pain. So people who have osteoarthritis at later years, they do need to get the surgery, which is basically replacing the joint. Anybody knows what's the most common joint that gets replaced in the body when we talk about osteoarthritis? Hip bone and knee, correct. So knee and hip are the most common joints that are replaced. There is replacement of the shoulder joint, but the most complex ones and most common ones are knee replacement surgeries and hip replacement surgeries. And they just basically replace the cartilage tissue with plastic and the head of the bones with metal balls. This is really important to remember that these individuals really need to do exercises because what you have placed in instead of their original joints are all plastic and metal. So if you don't use them, they actually get stuck in the position. And a lot of times when they don't do their exercises, they actually need to go back and replace those tissues and then make sure that they do their exercise. So I know people that just kind of ignore their exercise, say, oh yeah, I'll be fine. And then they ended up undergoing the knife again for the same surgery because they didn't follow the guidelines. The other one we have, which is, rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disease. Anybody knows what that means when you talk about autoimmune disease? Has anybody heard of that before, that word? Your body or your immune system attacks itself, correct? So in this case, what they're attacking is the cartilage tissue that is between the two joints. And as a result, it causes that cartilage tissue that was removed and was attacked to be replaced by bony callus. So instead of the joint being able to freely move, you're replacing it with bony tissue. So what happens to these individuals, and if you have seen people with rheumatoid arthritis, is their joint gets stuck in one position. So they can't close or open the joints, and if they try to do it, it's extremely painful. It does take years to develop. So a lot of people have rheumatoid arthritis. It's just not, it doesn't happen overnight, basically. It takes years, decades for people to develop. But again, when that process finalizes, basically they won't be able to use their joints. It's very obvious. Rheumatoid arthritis is really, really obvious in hands, where they basically fingers get stuck in one position. It's called rheumatoid arthritis. And you guys are going to take a break. I'll pull up a couple pictures so you guys can see a comparison between the two before we go ahead and get started on our new content. But that's basically what we're talking about for the skeletal system. Unless there is any questions, we're going to go take our 15-minute break and then get started on our muscular system. I think you're good. Okay, so I'm gonna pause our recording, go take a 15-minute break, and be back by 9:35, please. Recording. So we'll get started. So we finished a skeletal system just now, so we're gonna continue with our muscular system. This is usually the lectures that kind of go together because how muscles are directly connected to the skeletal system and the use of joints. You basically create your movements. So this is not something new. When you guys looked at your histology tissue or histology, you looked at the 3 different types of muscle tissue, which were a skeletal, cardiac, and a smooth muscle. This is kind of an overview of what you already learned. So we talked about a skeletal system basically being any muscles that you have attached to your bones, like tricep, biceps, your trapezius, your hamstring, your quadriceps, etc. They do have a pattern called striations. Their movement of these muscles are voluntary, as in you decide when to move these muscles. The shape of these cells, if you were to draw them, they are cylindrical, as you can kind of see on this image right here. And their other characteristic that is not listed here is that they are multinucleated per cell. So if you look at one single cell, they can have 6, 7 nuclei per cell. The type of cells that the way that we refer to them is myofibers. So for yourself, the word MY implies muscles. And whenever you use the word fiber, fiber implies something that's long or elongated. So skeletal muscles can get pretty long. They can get as up to 10 inches in length. So because of their length, we refer to them as myofibers. Cardiac muscles, which are only found inside your heart, they are striated, so they do have that similarity with the skeletal muscle. They are involuntary. Again, you cannot control your heartbeat or contraction of your heart. The shape of these cells are branched, which is basically what you see on the image down here. And they are called cardiocyte. Again, cardio implies your heart, and then cyte means cell. The one that we usually don't even discuss in detail beyond what is written here is your smooth muscles. This typically finds lining the hollow organs like your stomach, your intestines, your uterus, bladder, etc. They are non-striated, so you won't see that striping pattern of the light and dark color. Their movement is involuntary. Again, you don't control when your stomach or intestines move. Their shape is fusiform or spindle shape, which is basically implies they kind of have that thick center, and as you go to either end, they narrow down. And in terms of their nuclei, they're one nucleus per cell. And then heart, I didn't mention that, but for heart, you usually have a 1 to 2 nuclei per cell. Now, when we're talking about the rest of the lecture today, all of our focus is going to be on the skeletal muscle. So we don't really talk about these two again for the rest of the lecture. So we're going to focus on these skeletal muscle from now on. So what is the function of the skeletal muscle in our body? So they're helping us maintain our posture, giving us our movement. Basically, again, when you're thinking about it with the skeletal muscle, the skeletal system, they give us our movement. They support soft tissue. The best example I can give you for the supporting of the soft tissue is when you think about the muscles around on your belly. There's actually 4 layers of muscles, and you'll take a look at them when we get to that lab. But these 4 layers of muscles are basically protecting your intestines, your kidneys, your bladder, etc. So there is protection coming from the muscles. They're just not as strong in terms of protection compared to your skeletal system. They guard entrances and exits of the body. What we mean by that is muscles called sphincters. Hopefully you guys have heard of that before. So sphincters, just type it in the thing, are basically these round muscles that you can control. And then some of them are actually made up of smooth muscles, which we can't control. But the ones that we can control are found at the end of the digestive tract, at the end of the urinary system. So basically you have an anal sphincter and you have a urethral sphincter. And both of these are basically controls when you decide to poop or pee. These muscles and the other sphincters in children are not fully developed, especially when they're born, all the way to, depending on the age, to early childhood. And then when they start to fully develop, then they basically get better control over those activities. And then maintaining body temperature. So we already know that your body temperature is maintained at 37 degrees centigrade or 98.6 degrees Fahrenheit. So majority of that temperature or maintaining that temperature comes from the skeletal muscle movement. Hence, when you're cold, you shiver, and that shivering is basically rapid muscle contraction that helps you increase your body temperature. And then when you exercise, because of increase of these movements, then you start to sweat because your body temperature increases. So movement of the skeletal muscles significantly affect your body temperature. Hence, usually when you sleep, your body temperature starts to decline compared to when you are active or just during the daily activity. During a sleep, the temperature drops because you really have very limited skeletal muscle movement. Again, guys, if you do have any questions as I go over this, please let me know. Just type it in. Now, whenever we're talking about muscles, the 2 words that we actually use is myo or sarco. So whenever you see these 2 words, automatically think about muscle tissue. One of the cool facts about muscles is that you don't actually change the number of the muscle cells you have in your body. So basically, when you are undergoing fetal development in your mother's belly, which all of you guys have already gone, you were set with a certain number of muscle cells. Now, what causes the change in the size of those muscles based on the activities you do is that the number of the cells do not change. Rather, you make those muscles bigger by adding more protein into the muscle. So the process that muscle growth is through a process called hypertrophy, which basically, again, means that, again, you're really not making the muscle cell numbers or muscle cell numbers more, rather you're just making those cells bigger, the ones that you have, making them bigger than what they were actually originally there. So the question is, we talked about the fact that they are multinucleated. We talked about the fact that they don't grow, right? So how is it that they originally form? So when we're thinking about a fetus going in place to those muscles that gives them the capacity to contract and do their job. So during the first couple of months, so up to about 7th week, you basically don't have any muscles, or the embryo doesn't have any muscles. So around the 7th week, what is happening is you actually starting with stem cells, those stem cells that I mentioned earlier, called mesoderm cells. We mentioned that in the skeletal system as well. So mesoderms are basically, again, cells that have not been differentiated yet. They haven't figured out what they want to be. Now, eventually, some of these muscles, some of these mesoderm cells decide to differentiate into myoblasts. So again, look at the word. Myo means muscle, blast means immature, very similar to what we learned about the osteoblast. So now these cells are going to be muscle cells, but they are immature cells. So as they start to undergo their changes, what takes place, which is really important, is that some of these myoblasts start to clump up together. So instead of having individual cells separated, you're having them coming together and actually forming what we call a myotube, which is what you see here. So now, because each of the myoblasts that I started with had their own nucleus, and now they're all merging together, now you're going to form a structure which is actually multinucleated, as in it has multiple nuclei per cell, which is what we mentioned as one of the characteristics of the skeletal muscle. And then eventually this myotube starts to grow and develop and form what we consider a mature skeletal muscle cell or muscle fiber. Just to quickly note, a lot of my students get confused here because I'm using the word fiber. I mentioned this earlier when we're talking about it. The word fiber in this case is the same as, or is interchangeable for muscle cell. So I can use the word muscle fiber. I can use the word myocyte, which is basically a muscle cell, or I can just literally call it a muscle cell. So don't assume they're two different things. Muscle fiber is the same thing as a muscle cell, which basically means a typical cell. Next thing that we have is kind of looking at a typical muscle that we have in our body. So a typical muscle, which is basically an organ, like your biceps, your triceps, again, your quadriceps, your hamstring, etc. Each of these muscles will contain the following tissue: muscular tissue, which is kind of logical; connective tissue, which is the ones that we're going to see wrapped around your muscle; blood vessels, which is again kind of logical; and then nerves. Again, if you want to contract any muscle, you need to have nervous system inputting signals into the skeletal muscle for the movement. Not sure what is the classification. Classification of what? So all we're just talking about is when you're looking at a muscle in your body, like bicep, tricep, hamstring, quadriceps, It's an actual organ. Each of the muscles in your body is an organ, and these are the tissues that you can find inside that organ. Okay, now muscles, connective, blood vessels, and nerves. Okay, so what are the features of these skeletal muscles? So again, these are kind of logical. It's very similar to what I mentioned here, right? Blood vessels and nerves. But I want to make sure that you do have an understanding that you have a very significant blood supply to muscles, to skeletal muscles. Because again, when they move, they use a lot of energy. And for energy to be created, we need a lot of oxygen. So arteries are going to be the one that bring in the oxygenated blood to your skeletal muscle. And typically you have one or more veins. You have more veins actually collecting the deoxygenated blood from your skeletal muscles and taking it back to the heart. Every single muscle you have in your body has an innervation, which basically means they are connected directly to your nervous system. The point of connection between the muscle cells, individual muscle cells we're talking about, and your nervous system is called neuromuscular junction. And I will talk about that in a lot more detail later on. But again, neuromuscular junction, look at the vocabulary, guys. Neuro implies your nervous system or neurons or nerve cells. Muscular system, junction is the area where they come together, right? Kind of like freeway junctions. So for the muscle, understand this right now, and I'm going to come back and review it again. For a skeletal muscle to move, so if I do any type of movement, close my fingers, close my eyelids, as I'm talking, my facial expression, everything you see in terms of a skeletal muscle movement, that is happening because there is a nerve from my brain sending a signal allowing this muscle to contract. And the point of connection between my muscle and the nervous system is called the neuromuscular junction. Is this making sense so far, guys? Is there any question, clarification? Anything I need to repeat for you guys? Awesome. Okay. So when we look at your bone tissue last time, okay, we said that there were two types of connective tissue that's wrapped around your bone. And these two types of connective tissue were endosteum, endo being inside, and then the second type was periosteum, which was wrapped around the whole bone. So instead of saying the word like osteum, which basically implied bone, we're gonna use the word mesium or mycium, however you want to pronounce it, to represent your muscle tissue. So when we look at your muscles, we actually have three layers of connective tissue. They are endomysium or endomysium, perimysium or perimysium, and epimysium. Now again, look at the word. Endo means inside, peri means around, and epi means on top of. So among these three layers, epimysium is gonna be the one that goes on top of everything else. Perimysium is gonna be a level below that, so it's wrapped around the structure. And endomysium is gonna be the innermost layer of connective tissue. So let's walk through this. So let's take your biceps, the muscle you have right here, okay? That's your bicep. If I take the whole bicep out, okay, and take a look at the bicep, there is a kind of a sheer, almost plastic looking cover around this whole muscle, and that wrapping is referred to as the epimysium. Okay, so the wrapping that goes around my whole muscle is called epimysium. Now, if I look inside the muscle, and all of you guys, if you ever try to cook anything, you looked at a piece of basically meat, and I usually say red meat because it's easier to visualize. When you look at the meat, you see these patterns inside the muscle, which is basically what I'm describing here. These patterns you see inside the muscle. It's like these white lines going through this, okay? So the white lines that you see right here going through this whole muscle, like create little branch separations, sections, or segmentations. Each of these segmentations are called fascicles. Each of the segmentations are called fascicles. And the white tissue that is wrapped around it, which is the layer you can see right here, the white lines that you see going through the tissue is called perimysium. Perimysium is wrapped around the fascicle. So if I take one fascicle, which is what you see here, this is a structure being pulled out. Take my fascicle out and look inside the fascicle, then I have this tissue, this little structure right here as a whole. This represents a muscle fiber, which is the same thing as a muscle cell. And the tissue that's wrapped around it, again, see that clear, glossy looking cover on it? That's gonna be your endomysium, which is the innermost lining that is found around the muscle. So look at the layer again, one more time. We have endomysium, perimysium, and the thickest one that goes around the whole muscle is epimysium. Is this good so far? Making sense? So 3 layers versus 2 layers that we showed for the bone. So look at this, guys. I want to make sure you guys understand it. Take an individual muscle fiber, and you literally have thousands of them in each of your muscles. Take individual muscle fibers and wrap it around with a saran wrap, they say. And that individual structure is a muscle fiber. The wrapping around it is called endomysia. Let's say you take 20 of these structures you've created, you put them together, right? And then you wrap another connective tissue around this 10 structure. The wrapping that you've done, the second layer of wrapping that you've done, which is what you see here, is called perimysium. And then perimysium, the structure that is formed as a cluster of muscle fibers is called a fascicle, which is basically what you see here. What you see inside is a fascicle. Now, if I take hundreds of these fascicles, hundreds of these structures, smush them together, wrap another connective tissue around this, the connective tissue that's wrapped around the whole thing is called epimysium. And the structure that is created is my whole muscle, like your biceps, your tricep. You have to use the word whole muscle, guys, as in this is the whole structure rather than just a muscle. You cannot just say muscle because muscle can be applied in many levels. So let me ask you guys a question. If I say, pay attention, if I say, what is a fascicle made up of? What would you say? What is a fascicle made up of? I'm not talking about the connective tissue, but all I'm saying is, what is a fascicle made up of? Muscle fiber, correct. So your fascicles are made up of muscle fiber. What is the wrapping around your muscle fibers? What is the wrapping around your muscle fiber? What's the connective tissue that's wrapped around your muscle fiber or your muscle cell? Endomysium, correct? It's the innermost layer. What is the wrapping around your whole muscle? What's the connective tissue wrapping around your whole muscle? Epimysium, correct. What if I say, what is your whole muscle made up of? What is your whole muscle made up of? Many what? Many fascicles, correct. So many fascicles are put together to make a whole muscle, and each of the fascicle will have many muscle fibers. And basically each level has their own wrapping to strengthen the muscle and basically make sure as the muscle contracts and relaxes, they don't fall apart. So I answered your question too. That's good. Okay, so the other thing I want you to notice by looking at this picture, going back, is if I say, what is epimysium ends to be? So what is other than epimysium? So what is it actually becoming? So look at it. Here is my epimysium, right? See how it's going and it's actually kind of converging at the end of my muscle and form this point right here. That's an attachment to your bone. That is called the tendon. So if I ask you which of the connective tissues becomes tendon, your answer would be epimysium. So epimysium becomes your tendon. Make sense, guys? Awesome. And guys, there's at least a couple questions on this in terms of the anatomy of the muscles, in terms of the connective tissue, the vocabulary. Make sure you guys feel comfortable with the relationship between the vocabulary and the connective tissue for your exam. Now, the next thing we're gonna take a look at is muscle fiber microanatomy. So fiber, again, we're talking about cells. And then microanatomy is basically what is visible when we put it under the microscope. What can I see under the microscope? So we learned a bunch of vocabulary, if you guys recall, for a cell. We learned words like plasma membrane. We learned about cytoplasm. We learned about endoplasmic reticulum, etc. Hopefully these words sounds familiar to you. For muscle, we have its own vocabulary. So we, instead of saying site, which basically means cell, we're gonna replace that with the word sarco, which means muscle. Muscle is very unique because it has additional structures too, with different functions from the typical cell. So for instance, the plasma membrane, which was that phospholipid bilayer we mentioned previously, for the muscle fiber is called sarcolemma. So the muscle fiber plasma membrane is called sarcolemma. The space inside the muscle, which was called cytoplasm for all other cells, it's called sarcoplasm. So you guys can see the similarity between the words. Endoplasmic reticulum, which was the ER, simply put ER, in case of your muscle is called sarcoplasmic reticulum. A lot of people called it SR instead of ER. The main characteristic of sarcoplasmic reticulum, guys, is the fact that it is packed with calcium. There's lots and lots of calcium that's localized into this space, and it's extremely important for the action of muscle contraction, guys. So calcium is necessary for muscle contraction. And if I ask you, where can I find it inside my muscle fiber? Your answer should be sarcoplasmic reticulum. And please, when you write these, if I ask you guys for the full vocabulary, do not simply write SR. You have to spell the word as in sarcoplasmic reticulum. Now, this is a new structure, a structure called T-tubules. T-tubules is unique to the muscle, guys. And what it is if you take your sarcolemma, which is the plasma membrane, so let's say here's my plasma membrane, you can continue the plasma membrane and dip it down inside the cell and then bring it up. It's kind of like you create a little well or dip, or much deeper than a dip, a well. You create a well inside and then you come up. So kind of like if I was to draw it, if here is my plasma membrane, you continue going down, you dip it down, and then you come back up and then you continue. So this kind of really severe indentation that I've created, this little indentation, is called T tubules. So it's a deep invagination within your sarcolemma, which is your plasma membrane. And what it is essential for, it says for depolarization, fast depolarization. But another way for putting this is that it allows the electrical impulse, and you'll learn about that in just a few minutes, allows the electrical impulse to spread through your muscle fast. So it allows the electrical impulse to spread through your muscle fiber very rapidly. So it's kind of helps it speed up or accelerates the process. Now, some of these T tubules are surrounded by these cross channels that I'll show you in a picture called terminal cisternae. And these are extremely important because they actually connect back to your sarcoplasmic reticulum in terms of spreading the calcium through the muscle. Sorry. The last thing we have inside my muscle fiber, guys. So you take the muscle fiber. Majority of the space inside the muscle fiber is not taken by the nucleus or the sarcolemma or the sarcoplasm or the sarcoplasmic reticulum or T tubule. It's not taken by that. It's taken by these rod-like structure called myofibrils. Myofibrils. It's rod-like elements that are found inside the muscle fiber. So let me show you what I mean. Let's go back to the picture we had here. Remember this whole thing that I have right here, that's a muscle fiber. So what you're pulling right here, so basically this structure is a muscle fiber. Notice how inside of it you have individual little sticks. These sticks are basically what we call myofibrils. You can see most of the space inside the muscle fiber is taken by these myofibrils. So here's another picture, kind of zoom into it. So this structure as a whole is a muscle fiber or a muscle cell. And what we're pulling out of this is the myofibrils. Everybody remember striation we talked about earlier? We described it a lot. So striation. This is what a striation is. Look, dark band, light band, dark, light, dark, light. So these are basically beautifully, actually, truly beautifully organized. And if you don't have this organization that you can see, these beautiful striation, stripes, your muscle will not be able to contract. So the whole action of muscle contraction actually originates from this light and dark pattern that is visible on your myofibrils. And then what you see being peeled off right here, that's your sarcolemma, which is the plasma membrane of your muscle fiber. So let's take a look at this picture, guys. And again, these pictures are really important, so make sure you guys are comfortable with these. So right here, what we have is the bluest structures that you see beautifully formed. They kind of wrap themselves around the myofibrils. These are your sarcoplasmic reticulum. And again, what do we have inside the sarcoplasmic reticulum, guys? What are they packed with? Why is sarcoplasmic reticulum important for us, guys? Has a lot of what in there? Starts with a C. Calcium, correct. And we say calcium is extremely important for muscle contraction. So what you see in that darker blue color, all of these branching, That's your sarcoplasmic reticulum, which has lots and lots of calcium inside. The lighter blue shade that you see, these kind of the wells that I was mentioning, these would be your T tubules. So T tubules are basically, again, the ones that I've drawn for you here. It's a continuation of your plasma membrane and helps spread the electrical impulse rapidly through your muscle fiber. So we keep talking about myofibril, right? I keep showing you these structure and I keep calling them myofibrils, right? Over and over in these pictures, myofibrils. So what is myofibril actually? So we already learned they are densely packed, rod-shaped components that takes majority of the space inside the cell, right? So they account for 80% of the muscle cell volume. That's significant, guys. Like literally you're pushing everything to the side and said, this is my space. The reason they do that is because, again, myofibrils are the ones that are gonna cause the muscle to contract. They're the one that create the striation pattern that allows your muscle to contract. So if I take a myofibril and take a look at this, what is the characteristic of myofibrils? We talked about the striation already, right? So striation is that light and dark pattern that you see. It's actually broken down to these contractile unit called sarcomeres, and I'm going to show it to you. So right here, let's go back farther. So do you see these lines right here? So each of these units, so from here to here, and then here, each of these units are one sarcomere. And each of these are identified as contractile unit of your muscle. Now, what is this contractile unit of my muscles made up of? They're made up of myofilaments, which are basically proteins called actin and myosin. Actin is also known as thin filaments, and myosin is known as thick filaments. And if your brain hasn't blown yet, you're like, what the heck is she talking about? So let's slow down and then bring everything into perspective. So let me just go forward for a second. I just want to see what images I have so I can show it to you. Okay, so if I'm looking at my myofibril, okay, here's my myofibril, okay, just a single myofibril. You have thousands of them inside a muscle fiber. I can take it down and I'm gonna break it to smaller units. And each of these units now from here to here are my, and sorry, I can't write very well, but sarcomere. Okay, sarcomere. Okay. Sorry, I had an instrument that I could help me write, but I can't find it right now, so we're just kind of stuck with it right now. Now, inside the sarcomere, we have myofilaments. And they are two types, actin and myosin. So here, what I'm drawing as these boxes, and this is a really simplified version, guys. So these boxes are my myosin, which is basically, again, my thick filament. So all of the blue are my myosin. And then I have these tiny lines that partially overlap, not fully overlap. Notice there's partially overlapping. So they're partially overlapping with my myosin, and they are called what? Do you guys remember? Anybody? They're called actin. Correct. Or thin filaments. So look at the thickness, guys. Myosin is called thick filament, actin is the thin filament. So if I start to kind of backtrack and start from the smallest to the largest, so kind of clear your mind and try to follow what I'm saying, guys. From the smallest to the largest level of the muscle. The smallest structure I have are my two proteins called actin and myosin. If I put my actin and myosin in these contractile units, they're called sarcomere. If I line up hundreds of sarcomeres one after another, so this is a sarcomere, here's another one, line them up back and forth next to each other, that whole structure is called myofibril. Myofibril is packed inside a muscle fiber. Muscle fiber is packed inside fascicles, and fascicles are packed inside my whole muscle. So when I say my muscle is contracting, at the most basic level, I have actin and myosin that are causing contraction, which causes my sarcomere to contract, which causes my myofibril to contract, causing muscle fiber to contract, causing my fascicle to contract, and therefore my whole muscle to contract. So I'm going to type it in the chat box so you guys have that information. But I really want you guys to pay attention to this and make sure you guys are understanding this, because this level of organization is really important, guys. So make sure you guys feel very comfortable with this idea, okay? So actin and myosin are myofilaments that join each other inside a sarcomere. Okay. Many sarcomeres are lined up to form myofibrils. Thousands of myofibrils are inside muscle fiber. Then muscle fibers are packed inside fascicle, and many fascicles are packed to form the whole muscle. Okay. So when muscle contracts, I usually would have typed this on the board, so I would write it on the board, so I'm just typing it for you guys. So when muscle contracts, it starts with shortening of actin. Oh, sorry, no, it starts with interaction between actin and myosin that causes sarcomere to shorten, which causes your myofibril to shorten, which causes muscle fiber, fascicle, and whole muscle to shorten. Okay, and that's basically what muscle contraction is. Is this kind of makes sense? I know not everything is going to perfectly click, but does it make sense that when you think about muscle contraction, you start with the smallest structure, and that basically creates that domino effect, and it's most visible on the whole muscle? Make sense? Questions about this? No, it is the same. But whenever you talk about muscle contraction, it is the same thing as your muscle basically moving. Because without contraction, there's no muscle movement. Any other question? You can unmute yourself because sometimes the questions are too long, so you can just unmute yourself and ask the question. Oh, we'll talk about nervous system in just a second. So right now, all I'm saying is if there is a form of muscle contraction, whatever that is, that's going to create that movement, we start with the action or the relationship or the changes that is happening between the actin and myosin, and then you work your way up through the levels where you can actually see your whole muscle contracts, right? So don't think about, oh, my whole muscle contracts, there's nothing changing inside my muscle. No, the change actually happens at the microscopic level, which becomes visible at the macroscopic level of the whole muscle. Does that answer your question, Brenda?
I guess I'm just a little, I think it's gonna get more clear once we get into like the relationship between the nervous system and the muscle. Because my understanding was that in order for any movement to occur, then we have to send a signal from the nervous system to the muscle, where we have this, not the synapses, but the other word that you mentioned, right? The junctions. So then in the junctions, where the junctions come together so that the movement happens, because I understand that this is what the contraction happens, but then both of them will have to happen at the same time, or we have the signal first and then we do the contraction.
So what I'm teaching you right now is, sorry, thank you. So what we're talking about right now is the changes that is happening at the muscle level, okay? But as I mentioned earlier, these actions, the relationship between actin and myosin and eventual contraction of the whole muscle, does not take place until you have a response from your nervous system telling you your muscle needs to contract in the first place. So yes, you're completely correct, but I don't want to talk about the nervous system if we don't actually understand what's happening in the muscle first. So assume that there is a nerve impulse that causes the muscle contraction, and these are the changes that are taking place. Anything else, guys? You're welcome. Any other question, guys? Any other clarification or anything? Good? Okay. So couple other words that you're gonna see in just a minute. So I'm gonna just draw it on a picture and then we'll switch gears, because as soon as I move from this slide, we're gonna lose this slide. So I wanna just kind of go over this. So when we're looking at this drawing, so we have myosin, and then again, we have actin and myosin are interacting with each other right here. But notice that this interaction is only partial, right? So it's not the whole myosin and whole actin are fully overlapping with each other. So here is some of the names that you guys need to know. So from here to here, which is basically the length of my myosin. So from here to here, the length of my myosin. So I'm just going to do this part. This area is called the A band. And again, there's a description for it in your PowerPoint. I just don't want to move away from this slide. So the area where we have myosin, which is again the length of your myosin, is called the A band. The area where I only have actin, so right here to here, right here to here, from here to here. So I'm just going to draw it from either side. So from here to here, and from here to here. These areas where I only have actin or thin filaments, these are called I band. So I band and A band, okay? So this is I band, this is also I band, okay? So we have I band on either side, which is only actin, A band, which is the length of my myosin. And then I have another component, which I'm gonna draw in green, which is this midsection from here to here, where it's only myosin. It's kind of stuck right in the middle of the A band. So the area where it's only myosin, that's called the H zone. So we have H zone, A band, and I band. I band is actin only. H zone is myosin only. And A band is the length of the myosin as a whole. So pay attention to this, guys. We're not gonna go too much into detail about beyond this. When we look at the muscle contraction, pay attention to the word, guys. So when we're looking at muscle contraction, what is happening is the actin is going to interact with my myosin. Actin is going to interact with my myosin, and I'll show you what that interaction looks like. By this interaction, the actin is going to get pulled inside the myosin. So let me demonstrate with my pens. So imagine this is my myosin, this is my actin. Everybody sees the two pens that I'm holding? Right? Okay. So this is my myosin, this is my actin. Okay? So when your muscle is relaxed, this is the condition you have, right? So I'm gonna hold them together so you can see them. You have a region where it's only actin. You have the region that's only myosin. And then you have the length of my myosin, which is my purple pen. When a muscle contracts, what's happening is the actin is gonna move toward the myosin. So normally this is your relaxed phase. When your muscle is contracting, the actin, which is this part, is gonna go and move inside my myosin. Okay? So based on this, what is happening, pay attention to this, based on the scenario I'm describing, during muscle contraction, what is happening to my I band? Is it lengthening, shortening, or staying the same? During muscle contraction, is my A band shortening, lengthening, or staying the same? I want to answer more than three answers, guys. There are 34 of you guys. Okay. So it shortens, right? Because what is my I band in this section is this part, right? Where it's only red. When my muscle is contracting, what is happening to the area where it's only red? It almost completely disappears, right? So my I band gets shortened. Now, again, same scenario, guys. If I'm looking at this scenario, this is my I band right here. Length of my pen is my A band, right? And this area where it's only purple, that would be my H zone. So when my muscle is contracting, what is happening to my H zone? It also shortens, correct. So it actually, in reality, almost completely disappears. You won't see anything. It would be completely gone. So both the I band and the edge zone will disappear or shorten significantly when your muscles contracting. Now, again, look at the picture. In this scenario, sorry, my scenario, this is my A band, right? The length of my pen, my purple pen is A band. If I'm contracting the muscle, what is happening to my A band? Shorten, lengthen, or stays the same? It remains the same, right? Because my pen is still my pen, right? I didn't squeeze my pen to make it smaller, right? So my A band stays the same, but both my I band and my edge zone gets shorter. Good job, guys. Is this making sense to everybody? Is there something that just doesn't click for somebody? These are exam questions, guys. You need to understand that. Don't say like, oh, we didn't talk about this. So I can as easily ask you guys, what is happening to A band when the muscle is contracting? What is happening to the I band when the muscle is relaxing? Reverse everything. When the muscle is relaxing, I know the pens are my favorite things. When muscle is relaxing, you lengthen the structures. When you contract the muscle, you shorten the structure, with the exception of your A band. And I actually recommend this, guys. When you guys doing your own exam, just have a couple pens next to you and test yourself to make sure that you understand this. That's how I learned it originally, and I hope that helps you too. Like, pens are magical. Is there any question about what I have on this slide right here? If it's gone, it's gone. I can't come back to it. So I just don't want to move without having answered the questions. Okay. Okay, so let's go ahead and continue with our PowerPoint. What time is it, by the way? 8:00. So here is a kind of a picture of a muscle fiber. Wow, you guys, our internet connection is not that good today. So, so here is a picture. Here again is the beginning and end of your sarcomere. So these are your lines that marks the end and the beginning of the sarcomere. This is a contracted muscle, so you can't see your actin very well, but you can see a little bit of actin left on this side right here. And then the areas that are kind of darker black color, those are your A band, which is basically the length of your myosin. The only thing that I didn't talk to you guys about is your, sorry, I move this thing down here. The only thing that I didn't talk to you guys about is your Z disc, and I'm trying to find the slide for that, sorry. Okay, yeah. So H zone, we talked about it. A band, we talked about it. M line, I don't need you guys to know it, so you can ignore that. I band, we talked about it. It's the lighter region. Z disc is the only one that I didn't talk to you guys. Z disc is basically the ending. It says it's cone-shaped sheet of proteins on the midline of the I band. Don't need that definition. Best definition for Z disc is that it actually marks the boundaries for the sarcomere. So Z disc, boundary for a sarcomere. So it basically shows you where the sarcomere begins and ends. So I have a question for you guys. Thinking about the striation pattern, which is basically the light and dark pattern, what do you think your dark band is on your, or the dark section of the striation? Where does that come from? Is it from your A band, I band, or H zone? A band, right? Because it's thicker, so it's gonna be darker under the microscope. So that means your I band would be forming what? I band would be what, guys? Your light band, right? Literally, all you guys need to do is read this guy. The lighter zone. So when I talk about the striation pattern, I just want to make sure here. So the striation pattern on the muscle, right? The A band is the dark band or the dark region, and the I band is the light region. Okay. So again, to make sure that you guys making that connections between why is the striation pattern important? Why do I keep mentioning there is a stripes, there is a striation pattern? Because that's basically where your actin and myosins are and where they're interacting with each other to cause muscle contraction. All right, so myofilament, we already talked about it, but just kind of going over this slide quickly. You have actin filaments, which are basically the small one. They're extending from the I band and they go all the way to the A band. And you don't need to know that it is anchored in the Z disc. It's extra information. Myosin filament, which are known as your thick filament, are extended lengths of the A band, and they're connected to the M line. And again, you don't need to know the connection to the M line since I really didn't discuss that with you guys. You can ignore that piece. So mechanism of contraction. So we talked about the fact that myosin and actin are interacting with each other, right? That's basically what muscle contraction is. So I'm going to go back a couple of slides here. So here in this picture, in this demonstration for you guys here, what you see again, you can see a difference in the thickness. So the blue structure, that kind of like this beaded structure, that's your thin filament or actin. And what you see as this thicker structure with little heads poking out of it, that's your myosin. And there is an interaction between the heads of myosin or myosin heads and your actin filaments. So there is an interaction that takes place, and this interaction basically what causes the muscle contraction to happen. The way I described it for my students, if I was in a classroom, is imagine the tug of war, right? You have a rope and then your hands, right? So in that scenario, by looking at this picture, the blue line that you see, the blue beaded structures you see, which is your actin, is your rope, and your hands holding onto the rope are your myosin heads. So what you do when you do a tug of war, what do? You grab onto the rope, you pull, right? You let go, you grab another piece, and then you pull. So when we're looking at the actin and myosin, the same thing happens. So the little heads basically connect to the actin, they hold on to it, they pull, right? They let go, those myosin heads let go of the actin, and then they grab a different part and then they pull it back in. So that interaction is basically what causes the muscles to contract. FYI, I've seen a few people that came in late, I mean super late. You do need to sign in whenever you come in, so I know that basically you're tardy, sorry. You can send me a message directly, you don't have to send it to the full chat box, but if you did come in late, you do need to sign in still, and you get marked as a tardy and you do lose points for it, so do keep that in mind. So coming in at 10:45 is not an appropriate time for a class that started at 8. Okay, anyway, so I wasn't talking about that specific person. I'm just talking, it was a general statement. So I'm not pointing fingers at anybody. I'm just making a general statement. I'm just looking at the number of people that are in the chat box versus the number of people that were at the beginning of the class. Okay, so I'm gonna mute you. So, okay, so here's a question for you guys. If you're looking at muscle contraction, do we want every single muscle of our body contracting every single second of the day? Of course not, right? Kind of logical. So what prevents the interaction between myosin head and actin that leads to muscle contraction. How can we prevent that from taking place? And the way we stop that, the way we prevent that process from happening is using what we call regulatory proteins. Regulatory proteins, which are troponin and tropomyosin. So in this image you have on the bottom, again, the blue beads represent your actin. The little string that is covering those little heads, those little binding sites, are your tropomyosin, and the little yellow circles that you see are your troponin. So pay attention to this, guys. Under normal condition, when there is no muscle contraction, so your muscle is relaxed, the actin are going to be having these things called active sites, the way that they connect to basically to myosin heads. So when you're looking at the actin, these binding sites are completely covered with tropomyosin. Okay, see how they're covered? Those little black dots, openings are completely covered. So when that is the case, guys, tropomyosin covering the active sites of your actin, there cannot be an interaction between my actin and myosin. So when these little heads are covered, there is no interaction between my actin and myosin. However, when there is what we call calcium present, then tropomyosin is going to move, and that movement is going to basically allow the myosin and actin to interact with each other, and through that interaction you're going to have muscle contraction. So the reason troponin and tropomyosin are called regulatory proteins is because basically when they are present and they're involved, they prevent muscle contraction from taking place. And when they are moved, and I'll explain that movement in just a few minutes, when they are moved, then actin and myosin can interact with each other and cause muscle contraction. Again, guys, if you're sending me a direct message telling me you weren't here, I'm not pointing fingers at anybody. If you already signed in at the beginning, then you're okay. All I'm saying is about people who were not here the first 10 minutes of the class and did not sign in the first 10 minutes of the class. So if you are one of those people and are coming in at 10:45 and you don't see my screen, so you don't know who I'm talking about, all I'm talking about is those people. If you were here and you signed in, you're fine. You don't need to send me a message. Don't overthink this. I don't see your devices. I don't see anything. All I'm asking you is if you are late, you still need to sign in, and make sure when you sign in, then that's it. That's all I'm saying. So, okay, so what we have here is now connecting the muscle contraction concept to what you were asking me, Brenda, earlier about nervous system, right? So a skeletal muscle contraction requires an input of the nervous system, okay? So that's what I was telling you earlier. And the best way for me to describe this concept for you is the following, that when we look at our nervous system, if a person is healthy, every time they want to move a muscle, they're perfectly okay. However, if a person has a stroke, one of the most common things that you have, okay, in a person that has a stroke is what? What's the most common symptoms you have? Guys, what's the most common sign if somebody has a stroke? You have never seen a stroke patient? All right, drop in face, but what is more specifically, how would you describe that? Not necessarily numbing, but muscle movement, paralysis, correct. So typically half of their body is paralyzed. Yeah, again, there's different severity. The drooping on the face is the usual most common thing, but you actually, most of the time you see paralysis in about half of the body. So the reason for this is when somebody has a stroke, basically the neurons and part of the brain that was controlling the skeletal muscle have been damaged. So the nervous system that are controlling the skeletal muscles were damaged, okay? And because of that damage, basically, you have lost the ability to effectively move your skeletal muscles. Now, I want you guys to make and understand this distinction. There is a difference between muscle being damaged versus the nervous system being damaged. If somebody has a stroke, there is no damage to their skeletal muscle. The skeletal muscle are perfectly healthy. It's the connection that causes those muscles to move through the nervous system is damaged. Hence, if somebody has a stroke and they survive that stroke, what's the most common treatment you see for that individual after their stroke as part of their process of treatment? Therapy, correct. They do PT. Physical therapy or occupational therapy is the most common type of treatment you see somebody after a stroke undergo. Because, why? Because what are you doing? When you're doing the physical therapy, what is that idea? What's the idea behind it? It's not a stimulus, it's relearning. Relearning is a better word, retraining, correct. You're trying to help your brain re-establish connections between the nervous system and the muscle so the muscle can actually move and continue with the basically the regular process before the stroke has happened. So hopefully that makes sense. So when we're thinking about nervous system is essential for basically allowing the skeletal muscle to move. If there is damage to the nervous system, the muscle movement ceases to exist, but that doesn't mean there is damage to the muscle itself. Muscle is healthy, the connection of the nervous system is damaged. Okay, so when we're talking about nervous system, and again, shouldn't be something new to you guys. Nervous system is basically when we have, the most common cell inside our nervous system are your neurons. And this should not be new because you looked at the tissue samples in the histology lab. So neurons have three main parts to them. You have these little extensions called dendrites that are receiving the original electrical impulses. You have this chunky piece that has the nucleus in it called cell body or soma. You have this long extension called the axon. And then at the end of the axon, you have what we call the axon terminal. So axon terminal is basically what we end with. Now, these are the three main parts. Dendrite, cell body, and axon are the three main parts. So axon terminal, as the name implies, is kind of the ending of your axon. Why is axon terminal important to us? Because they carry something called, or they store and carry something called neurotransmitters. Neurotransmitters, which basically means they're going to transmit a signal from a neuron to another environment. So they're transmitting a signal from one environment to another. You may have heard of some of the common neurotransmitters like dopamine, epinephrine, and oh my God, now I'm like literally drawing blank. There's like quite a few of them, but dopamine is the most common one. Adrenaline is another one. The one that we care about when we talk about neurotransmitter for muscle contraction is called acetylcholine, or simply ACH. ACH is the easiest way to remember the neurotransmitter that are involved in muscle contraction. So let's take a look at this picture, guys. Here is an image of where your neuron is communicating with your skeletal muscle. So here is my neuron. Here is the end, this chubby end that you see right here is your axon terminal. And these little circles with the green dots in it, those are vesicles that are carrying the neurotransmitter ACH. And again, ACH stands for acetylcholine. So pay attention to this, guys. When there is a muscle contraction, what causes that to happen is first, electrical impulse is coming down your axon, which is this structure right here, and reaching the axon terminal, okay, which is this space. That electricity, that electrical impulse that is associated with your neuron causes the neurotransmitter ACH to be released into this space right here. Now, this space is called the synaptic cleft. Okay, so this space is called synaptic cleft. Now, why do I care about the neurotransmitter? Again, it's a way for me to communicate with my muscle fibers. So these little neurotransmitter ACH are going to bind to my muscle cell membrane, which you see right here, to these tiny receptors in blue called sodium-potassium channels. Sodium-potassium channels. So neurotransmitter gets released into my synaptic cleft and then binds to these channels on my muscle cell called sodium-potassium channels. So let's take a look. I just want to make sure I don't have that. So here, I'm just kind of going over the same thing over again, guys. Electrical impulse is coming down, right? This is your axon. It spreads through the axon terminal, which you see right here as these yellow little podocytes. Inside your axon terminal, you have these vesicles that are packed with your neurotransmitters, ACH. The ACH neurotransmitter bind to these channels that are called sodium-potassium channels. You see them as these little purple structures right here. And that causes, neurotransmitter causes the sodium and potassium channels to open up and allow sodium to come in, lots of sodium to come in, and little potassium to get out. This change of ions, this coming of the sodium and getting out the potassium, creates electrical impulse inside my muscle cell. Now remember that you need to spread your electrical impulse throughout your muscle. So remember this structure, the tube that was going down the thing? Do you remember what it's called? No, it's not. I'm not talking about terminal cisternae. This little tube that is coming down, what is this called? Anybody remember? T, it's literally called T what? T tubules? No? T tubules, that's literally the name of it. And that's gonna spread the electrical impulse. So I'm gonna type this for you guys so you have that information. I don't want you guys to get overwhelmed and say, what the heck is she talking about? So we're gonna do a step-by-step in the chat box and I'm gonna show you on the picture. Okay, so I'm gonna number them. So the first thing is electrical impulse comes down the axon and reaches my axon terminal, right? As you can see, electrical impulse comes down, the red arrows that you have reaches the axon terminal. Second thing, electrical impulse at the axon terminal causes the vesicles filled with neurotransmitter ACH to be, change it to ECH, ACH to be released into the space called synaptic cleft, right? So here is the synaptic cleft, right? So there's space, here is my vesicles for the neurotransmitters, they're little green dots, and it gets released into this space called the synaptic cleft. Third thing that happens is ACH binds to my sodium potassium channels and open them. Right? So again, these little purple things that you see on the image, those are your sodium potassium channels. As soon as they see ACH, they open up. Next thing that happens is sodium moves in at a higher rate than your potassium leaving the muscle cell. Right? So that movement of sodium coming in and potassium leaving, that's creating the electrical impulse. So movement of sodium and potassium causes electrical impulse inside the muscle fiber or slash cell, right? Because we said muscle cell and fiber are the same thing. Now, again, when this electrical impulse is created, which is this pink arrow you're seeing going down right at the surface of the muscle, now I want to send it down into the muscle. So the next thing is electrical impulse is spread through the muscle fiber using T tubules, right? T tubules are these little extensions that we draw here. Is this making sense so far? Give me a thumbs up if you guys are clear so far. Okay. Awesome. So the next thing that is happening now is, remember that we said that T tubules are surrounded by the sarcoplasmic reticulum, the SR, that contains a lot of calcium, right? So electrical impulse that is in the muscle now causes the calcium in the sarcoplasmic reticulum to be released into the muscle fiber. So what you're basically doing is now you are, by that electrical impulse, by using that electrical impulse, you're going to open it up. You're going to open up the calcium and, sorry, you're going to open up the sarcoplasmic reticulum and release that calcium inside your muscle fiber. Remember, we need that calcium for muscle contraction. So let's go back to the previous picture that I talked about. And now I'm going way back here. So here's the T. Now, next step. Calcium is going to bind to troponin. This is really important, guys. It's going to bind to troponin and move it. Remember, in the image that I'm showing you, troponin are these little yellow circles. Next thing that you have is troponin connected to tropomyosin. So when troponin moves, right, so does a tropomyosin. So you basically removing that little string that you see in the picture and those yellow dots. You're moving both of those. Now, why is that important? The movement that we described in the previous step is going to free up myosin binding site on the actin. Okay, so those little circles that we said, those are the free spaces where the things can interact. Those are gonna free up. So when they free up now, actin can interact with myosin and cause muscle contraction, which is the whole key reason why we're doing all of these processes. And you guys can, again, just take a screenshot of this. You don't have to retype everything yourself. You can just take a copy and paste it. So hopefully that's what you're doing. Is there any question about what I've described to you guys so far? If it is, unmute yourself and ask your question instead of typing it. I don't want to create space in the steps that I've included if somebody's typing it already. So what we're describing is both under neuromuscular junction and muscle contraction. So it's both. So if you go forward to the picture that I was showing you earlier, so this picture that I'm showing you here, okay, where the axon terminal is and then the sodium potassium channels are, that's the neuromuscular junction. But what we're explaining in terms of the T tubules, the troponin, tropomyosin, that's related to the muscle contraction. So there's two concepts we're connecting together right now. Well, and here, guys, again, when we're looking at the neuromuscular junction, is literally where your axon terminal is communicating with the muscle fiber. That area is known as the neuromuscular junction. The steps that I've described to you guys, these 11 steps, is really key to your understanding of muscle contraction. You will have questions on this. So please be clear about the steps involved. The other thing I want to mention here is after you guys are done with your, when you guys are working on your lab, I'm going to post a picture under your week 5. It's just a single picture. That kind of shows, it's my hand-drawn picture that I usually do in class, but I can't do it on the computer. It kind of brings this whole concept of actin, myosin, troponin, tropomyosin, neuromuscular junction, sodium potassium channels, everything that we described here, it's going to bring everything together. So please take a look at that picture. That image will be part of your exam where I ask you guys to identify specific components from the image. And the most common confusion I get from my students is, oh, it doesn't seem like any of the pictures that are in the PowerPoint. Yes, there isn't, because I'm not a, I don't get paid to do drawings, basically. So I'm not a good drawer. You guys can see from just my basic drawings. But it is something that is important. It's a simplified process that explains not only what's happening in a neuromuscular junction, but also what leads to the actual muscle contraction. So please, during this time before your next exam, take a look at the image that I'm going to make available and make sure you guys can complete the labeling on that image on your own. Okay, so let's not talk about lab. My brain is not there yet, so let's finish up the lecture and then we'll switch to labs. Okay, so we have a few minutes, so let me just go over a couple more slides and then we'll end the lecture for today. So when we're talking about the muscles, another thing that I want you guys to know is when we look at the muscle in terms of identification, you can look at the pattern of the fascicles, and they are going to have various orientation. So what does that mean? Is when you look at the muscle, I'm just going to show you this. Each of these muscles have a very particular shape in terms of where the tendon is and where the direction of the muscle actually goes. So one of the most common type of muscles we have in our body is a muscle called fusiform. So fusiform basically implies that the fascicles are kind of chubby right at the center. And as you go to the either end of your muscle, it kind of narrows down to two tendons that are basically the points of attachment for your muscle. These are relatively strong muscles, and the most common example of it is your biceps brachii or your triceps brachii, which are the muscles of your arm region. And then the gastrocnemius muscle, which may sound new to you guys until you actually do your muscle lab. That's a muscle that's your calf muscle, basically, the muscle the bottom on the back of your leg. Another type of muscle we have is parallel muscles. So these typically relatively weak muscles compared to the fusiform muscle. As the name implies, you don't have that narrowing at the end. You kind of have a very uniform thickness to the muscle from the beginning to the end. And these muscles are most commonly found in your abdominal region. So your rectus abdominis muscle, what we call as your six pack, that's your rectus abdominis muscle. And then sartorius is another muscle that you can find in the thigh region on the anterior of the thigh. You'll learn about this when you guys look at the muscle tissue in a 2 weeks time after your lab exam. Pennate muscle is the one that's shaped like a feather. So you basically have your tendon runs right in the middle of the muscle, and all the fusiforms, all the fascicles are coming into this tendon. You can have one of these tendons run in the muscle, and that's called unipennate. Like your semimembranosus muscle, again, another muscles of your hamstring muscle, the back of your thigh. If you have two of those, so two structures, which I didn't show you a picture, but there's two of them, is called bipennate. Best example is your rectus femoris, a gigantic muscle in the middle of your thigh. It's part of your quadriceps, if you guys are familiar with your muscle workout. And then multipennate is the picture that I showed you here. It's your deltoid muscle, which is basically this triangular muscle goes over your shoulder. Again, you'll learn about these next in 2 weeks time, so it wouldn't be completely unfamiliar to you guys. You also have a muscle called circular muscle. So again, as the name implies, the pattern is circular. Best example is a sphincter muscle that I mentioned earlier, and then orbicularis oris. Literally, you have muscles that are around the eye called orbicularis oculi, and around your mouth called orbicularis oris. Oris means oral, right? You're opening for your mouth. And then lastly, you have muscles called convergent muscle. Convergent muscles is basically you have this fan-shaped muscle. So kind of open on one side and then all converge to one point. Best example of this muscle is your pectoralis major. So the chest muscles that many men are very proud for working out. Sorry, no offense to men. It's actually good for women to work out that muscle too. There are benefits to that. It gives you a boost without actually getting a surgery. So this one I already talked about. Just a quick thing. I want to see how far we are toward the end of it. Okay, actually, I'm going to stop here because I don't want to like overwhelm you. I think if you're not already overwhelmed with information. So I'm going to stop here. We're going to finish up the rest of the muscular system because there's only a few slides left. So we'll finish up this next time, and then we'll start our blood lecture, I believe, for next week, which is a shorter lecture among the other ones. Is there any questions or any clarification on our lecture so far before we go ahead and take our break so I can do your breakout group for your lab? Nope, you guys are good. Everything is beautifully clear. I'm that good. Please, guys, I know this is a complex process, especially when it comes to the neuromuscular junction and muscle contraction. So please take your time, make sure you review the information. email me through my campus email if something isn't clear, or come to the office hours next week so we can go over them so you can know the information for your exam, because I really do want you guys all to do well in your exam. So take that a step. If you do have any questions, contact me so I can clarify anything that might be missing. And of course, remember that all of your PowerPoints are available under the Zoom recording, under the cloud recording. So make sure you guys, if you want to ever come back and review what we lectured, they're all recorded. So you guys are welcome to take a look at any part of this lecture that you want for later on. Okay, so let me stop. Sorry, not my video. So let's go ahead and take our break, or we'll be back by 11:30.